Hi, this is Gwen for our final round of chapter review. These are chapters 14, which is management of the acutely ill and medically complex older patient. Chapter 25 is our post-acute care management of the older adult, with 26 discussing home health management. These may be fields that my course mates, are familiar with. Just updating on some concepts through this management. Chapter 14 is acute care. We're addressing persons with multiple impairments and probable multiple deficits, including potential cognitive and social factors. Our PT knowledge and skills are greatly needed to have a thorough screening for proper intervention, and we need to work effectively with the older client in that acute care setting because of the potential of comorbidities. As anticipated, review of systems, including the admitting template, primary diagnosis, secondary diagnosis, any past medical history, any risk of heterogenics, any medications, and the psychosocial factors. With the acute care patient, we're definitely looking at laboratory values and reports, including key concerns are electrolytes, anemia, blood glucose, coagulation, EKGs, any surgical reports. The chapter had numerous charts concerning all of these different values. I specifically like the one on the different electrolytes, showing what are we noting with increase and decrease. So I added it to the slide. And then there's the system review portion, including mental state, vital signs, nutritional status and physical appearance. What's the body weight composition? Our concerns with this patient: is there any red flags for orthostatic hypotension? Any response to exertion? The need for a pulse ox for our O2 levels and auscultation? And nutritionally, concerns of blood glucose levels, dehydration, and potential dizziness that may occur. We're also working at a prevention level with our acute care patients, including primary health behaviors, secondary things like modification of the disease and eliminate risk factors, and tertiary is working on functional mobility. A concept in doing this was called recovery coaching. They used the concept of coaching as a team, including putting a label on it, stepping back and listening, identifying opportunities, and working with a team for the clientele for better outcome and better prevention methods. Chapter 25 focuses on the post-acute care management for our older adults. This is a focus on post-acute care settings with discussion primarily on short-term skilled and long-term care facilities. With inpatient rehabilitation facilities, the patient must meet specific criteria. That means that it needs to be reasonable and necessary, significant rehab potential. They require at least 2 therapies between OT, PT, and speech therapy. And they must fully participate. They must be able to participate a minimum of 3 hours, 5 times a week. And box 25.1 will list some qualifying diagnoses. With post-acute care, we're looking at skilled nursing facilities or long-term care facilities. With the skilled nursing facilities, they must be certified by Medicare. Traditionally, skilled nursing facilities did have lower functioning patients who were there for longer terms, but currently there are more increased expectation that the patient will be discharged to the community. With long-term care facilities, the leading cause of admissions are decreased cognition, incontinence, and falls that related to decreased function. There's also a growing increased cost of care, with 50% of the population over 85 in long-term care, 10% of the age between 65 and 75. Long-term care is considered custodial, and patients do not necessarily receive any skilled intervention or any periodic review. PT management of the skilled nursing facility and long-term care, as always, goes through exam and evaluation. Some of the chief concerns are fall and fall risk factors, with 30% of patients in nursing homes will fall and an average of 2 times per year. A fall assessment team is put together analyzing the reasons for falls that we have discussed previously, including the chronic disease, cognition, deconditioning, medication side effects, unsafe equipment. Also look at patterns of falls and plans for intervention. Evaluation is system review, as usual, including things like hearing, vision, and bowel and bladder issues. Noted pretty specifically in the text that manual muscle tests are not a good correlation of function and probably not good for this patient population. And a functional assessment baseline is necessary. Table 25.1 gives you some good functional assessment baselines. Intervention includes exercise with the active participation in meaningful activities. It is noted that high-intensity resistor training in skilled nursing facilities has been shown to be safe and feasible. A program called iStrong, or Intensive Therapeutic Rehabilitation for older skilled nursing home residents, is one that was investigated, showing good results. Gait training notes that speed is a predictor of function. If you're less than 0.25 meters per second, you're particularly ADL dependent. We need to monitor for compensatory strategies and add dual task activities when gait training. Balance training, PTs need to again address dynamic activities such as eyes open, eye closed. Patient needs to be able to dynamically recover. And transfer training is a theory of overload and specificity. Some unique challenges in the long care facility are fall risk reduction, restraint reduction, pressure ulcer management, and risk reduction. Restorative programs, specifically programs such as turning and positioning programs, wheelchair mobility, endurance program, ADL programs. Challenges of dementia and depression are noted. And future trends with changes of costs for payment and methodology potentially changing. Chapter 26 is on home health, and the PT needs to be able to tolerate some situational isolation. They need to know that there's going to be large documentation. There's going to be unexpected circumstances, a lot of variability, and must be efficient in time management. The definition of homebound was discussed with the author concerned about the definition for homebound, including criteria 1 and criteria 2, and that it must be taxing for the person to leave their home. Boxes 26.1 and 26.2 represent definitions or criterias. The role of the PT in home health is to promote independence in essential ADLs, integration into the community, minimize risk for rehospitalization. Reasons for rehospitalization are noted to be lack of care coordination and poor discharge planning, with the major causes of patient and family not engaging in the process, gaps in the process, and no communication among providers. So there's solutions noted in a couple of references on high-intensity, multi-component, and multidisciplinary intervention, which you can go through. All of these need to be done for a smooth home health intervention. Also important is the variability of the home environment. We need to be sensitive to cultural and social economic concerns, as well as ethnic biases and sensitivity to care. Home health is loaded with documentation including OASIS, or Outcome and Assessment Information Set Instrument. Also noted as medication reconciliation, fall risk screening, home safety assessment, functional assessment, emergency situation documentation, and goal setting, as well as episode of care, including a projected number of visits and training, what the initial PT education was, and case conferences with other providers, including physician communication. There are limitations of home health. One of the key ones is pain. Elderly are disproportionately affected. There's racial and ethnic disparities. Depression often accompanies chronic pain, with pain self-efficacy and health literacy of concern. And reducing depressive system results in decreased pain intensity and increased function. And there's a great deal of modifiable psychosocial risk factors that can be worked with for pain and the home health patient. So the questions I have is, how does pain impact patients' willingness to participate in PT activities in the elderly, specifically in these categories of acute care, skilled nursing facility, long-term care, or home health? And social economic status may impact their access to care, specifically at all these levels. What steps does or can a PT take for best care or best practice? And how does social economic status impact care for those needing this service? So this is the list of reference, and thanks, and I look forward to our discussion post.